Claire, am I audible? I just wanted to make sure.
Yes, you are.
Okay.
So I'll go ahead and get started. Thank you all for joining us for tonight's lecture, Left Atrial Appendage Occlusion Devices and Echo. Many thanks to our presenter, Dr. Deepak Kumar Pasapula, a cardiology fellow at Mercy One North Iowa Heart Center and the co-chair of the ACC Iowa Chapter FIT Council. We do have more FIT lectures coming up, so check out our Twitter account and our website calendar for the offerings for the upcoming months. And without further ado, I'll hand it over to Dr. Pasapula.
Thank you, Claire. Welcome everyone. I hope I'm audible and clear. Unfortunately, due to family emergency, I had to crash in Chicago, so I'm trying my best from a remote Wi-Fi network. So sorry, and my sincere apologies if it is like a little scratchy. So all right, without further ado, let's start. Are you able to see clear on my screen?
Let me check on that. I believe that I am still sharing, so I will stop so that you can go ahead and share.
Okay, let me share my screen. All right.
There we are.
All right. You're able to see my screen right now, right?
Yes.
Okay. All right. So let's talk about left atrial appendage occlusion devices. We'll check on mostly percutaneous LAO devices and also integrate that with echocardiogram and see what we can learn. By no means I'm any expert in it. Like, and I did my due diligence, read about it, and with my experience and my research. So I'm trying to put this lecture together. So please chime in if there is any expert, if you have any thoughts, comments, or any suggestions. So I don't have any disclosure. So let's start with a case. A 72-year-old female with history of hypertension, paroxysmal atrial fibrillation with a CHA2DS2-VASc score of 3, which is translating to an annual stroke TIA and systemic embolization risk of 4.6%. Okay. She is only on aspirin due to history of GI bleed. That required multiple transfusion, ED visits, endoscopy. Now, this current hospitalization, she presents with acute onset of left-sided weakness. So for the worker demonstrated that on the MRI of the brain, she has right MCA territory and left MCA territory infarct. So 2 areas. Here is the TEE, and I hope this is playing over there. So this is the PW at the left atrial appendage. I want to highlight the left atrial emptying velocity of less than 20 centimeters per second. And I hope you guys are able to appreciate a big thrombus here in the left atrial appendage. Okay. So in this patient who has contraindication for long-term anticoagulation, one would ask, what are my options? And then what can I do to prevent this patient from having future strokes? So obviously, I mean, this is not an audience poll because we're talking about left atrial appendage. So I just wanted to kind of give a clinical scenario and so that you can think about such patients. I'm pretty sure we must have encountered this during our clinical practice. So without any further ado, let's see what we can learn here. So leading causes of death in the United States starts off with heart disease being number 1, then cancer, and then yes, COVID-19 ranking number 3rd there. Unintentional injury and stroke. And this is as per the paper published in JAMA in 2020. Now, there is a very strong association, as we all know, with atrial fibrillation and stroke. More than 90% of embolic strokes have been described to originate from either left atrium per se or left atrial appendage, and especially more so in non-valvular atrial fibrillation patients. Now, AFib is associated with 5-fold increase in ischemic stroke and 2-fold increase in all-cause mortality. Now, AFib it's kind of a systemic disorder, not per se. I would think as if it's a disease which is limited only to left atrium or left atrial appendage. And then our historical way of treating this with stroke prevention is by either vitamin K antagonist direct thrombin inhibitor, dabigatran, bivalverodin, or gatraban, or factor 10A, the NOACs, which are not NOAC anymore. They have been here for quite some time. So, rivaroxaban and apixaban, which I'm pretty sure everybody has been familiarized with. So, just to kind of brief touch on what does guidelines recommend, it's kind of a class 1 indication for male having CHA2DS2-VASc score more than 2 and women with a CHA2DS2-VASc score more than 3. And in recent guidelines, NOAC take precedence over warfarin. So, that's a whole lecture by itself. I just wanted to kind of reemphasize that fact. And then there is updated atrial fibrillation management guidelines coming up in somewhere around in March, April. So it will be exciting to see what new changes are there in terms of stroke prevention and management of atrial fibrillation. So here I wanted to kind of point out between, like, whenever we make that thought of, okay, I need to anticoagulate this patient, there is always the yin and yang, like, okay, is there a high bleeding risk, or is there, like, better prevention of stroke? So we always resort to, like, CHA2DS2-VASc score and Has blood score, right? So I also wanted to point at a couple of coincidences between CHA2DS2-VASc and the Has blood score. So especially the hypertension gets a point on both sides, age, followed by stroke, TIA. So that's kind of a 2 point on the CHA2DS2-VASc score and a point on Has blood score as well. So this kind of, like, gives you an idea, okay, based upon these risk factors, I need to anticoagulate, but there are also risk factors for this patient to have high bleeding risk. So what do I do in this circumstance? So it's kind of a shared decision making, and you use your clinical judgment and you talk to the patient and what they are comfortable in pursuing. And we also have a couple of barriers for anticoagulation. Number one, as our patient had high bleeding risk, that's the most common which we encounter these days. Cost, especially when we are talking in terms of NOACs, and then, like, people not having, like, enough coverage still in terms of their insurance covering for their cost. And then non-compliance, like, patients forgetting to take that. So these are a couple of the things which we as clinicians constantly think about when we talk to the patient in the clinic initial visit or subsequent visits, like, are you taking your medication? Have you been noticing blood in urine, blood in stools? Are you missing any doses? So something which we need to think about every clinic visit. Then, so let's talk about a couple of indications for LAO, and this is based upon the Medicare, Medicaid indications. So the patient needs to have a non-valvular atrial fibrillation, have a CHA2 score of 2 or CHA2DS2-VASc score of more than or equal to 3, and obviously shared decision-making between an independent non-interventional physician, and that should be documented in the medical records. Suitable for short-term warfarin, but deemed unable to take long-term anticoagulation. So, and why, we will talk about it in upcoming slides. So, and as always mentioned, like, left atrial appendages are second line, not a class 1 indication. So we also need to know some of the contraindications for appendage occlusion. So it's somebody who has, like, our patient who has intracardiac thrombus, who has huge thrombus sitting in the left atrial appendage, he would be kind of a contraindication. No brainer, kind of, right? Yeah. So presence of ASD closure device, again, why we will talk about it. And left atrial appendage anatomy not able to accommodate the device. And then somebody who's having active infection like endocarditis, and then who's having active bleeding, and then somebody who has allergy towards aspirin or T2Y12 inhibitors, and then somebody who has a very large intra-atrial shock. So these are some of the contraindication, and also somebody who has atrial septal aneurysm, like, one which is defined as more than 15 millimeter of length or excursion distance more than 15 millimeter. So based upon the 2019 updated AFib management guidelines, may it be percutaneous LAO or cardiac, like surgical LAO, they get a 2B recommendation. So if somebody who has percutaneous left atrial appendage occlusion may be considered with atrial fibrillation at increased risk of stroke to have contraindication for long-term anticoagulation. That's kind of for percutaneous. And then when we look in terms of like surgical, if somebody has atrial fibrillation, high risk for thromboembolism, is like something going for bypass surgery, it's kind of for class 2B, like for if you would prefer to close that left atrial appendage. So, and then I just kind of wanted to emphasize on the anatomy here. This is like really good slides by Dr. Kalyan Mishra Kumar with regards to his book, Atlas on Cardiac Anatomy, and I took this from his book. So here is your left atrial appendage. As you can see, it's kind of lifted and sits on top of your LV summit, and you have a major blood vessel traversing beneath. And then you have a very close proximity to your superior pulmonary vein, and then your circumflex artery down beneath. So these are some of the important structures which you would want to consider before you're thinking about in terms of left atrial appendage. What are the surrounding structures which I need to pay attention to? And this is kind of an cross section of one's left atrial appendage, and you're looking from inside. And as you can see, there are like so much trabeculations, like so much lobulations, which prevents the emptying of the blood and is the nidus for your thrombus formation. More lobulations is the higher chance of one forming thromboembolism over. And this is kind of a like pictorial representation of how the catheter travels, comes through your IVC. Like you go through a 14 French sheet from your groin, like go IVC, do a transeptal puncture, and go across the mitral valve, and then you reach the left atrial appendage here. So this kind of just tells you what is the mechanism and like how mechanistically it is. Although this is an ablation catheter, like your Watchman device implantation catheter would be something similar to. And then let's quickly touch base about a couple of morphological differences in the left atrial appendage. This is really obviously the chicken wing. Here is your gross specimen, and then this is based upon your CT reconstruction, your kind of lobulation on the CT. And then this is cactus morphology. And this is your windsock, and this is your cauliflower. So the chicken wing, as I said, it has like one lobule, least likelihood of forming thromboembolism. Whereas when you look at this cauliflower morphology, all this like small lobules put you at higher risk of hiding a blood clot over there if one is not therapeutically anticoagulated and it becomes a nidus for your stroke. So when we analyze left atrial appendage, you look at a couple of parameters. One is what is the size, what is the left atrial emptying velocity. That is much more informative for us to say, okay, this guy's high likelihood of future stroke, or if there is a sludge in that area, or if there is very thick echo density which you see in that area. So left atrial emptying velocity, I just wanted to kind of point out here the waveforms of your, when you go to your mid-esophageal short axis view, kind of counterclock from there, try to find your left atrial appendage, which almost kind of shows up on this spot here. And then once you have it, you try to keep it on axis and try to go up on the degrees, go down on the degrees, try to look at all right from 0 until 130, 140, just to make sure you're looking at all the lobules. Because as I said, it can have more than one lobule. It could be cauliflower or cactus, and one of the lobule might be hiding a thrombus over there. So it becomes very important that you look at all the lobules. And we have we have measured, I think it was one patient in a vein 130 or 140, we were able to find out a lobule which had thrombus, and then we had to abort cardioversion. So something which you would want to make a special note to. And then once you identified that, just try to put a PW Doppler over there and then getting your velocity. And what you would be interested is your emptying velocity. So kind of waves which you look at, this is one when you are in sinus rhythm. And this, as I mentioned, in atrial fibrillation, you call these as F waves. When you put your PW in your left atrial appendage, kind of irregular, chaotic. when compared to one you see in the sinus rhythm. So the first one is your early, I mean, start with when you always correlate with your ECG. With correlating with the P wave is your late diastolic emptying velocity. And this is what we really worry about, the cutoff of being 20 centimeters. And then followed by your systolic reflection waves, and then early diastolic emptying velocity. So, what is the real function of atrial appendage? Is it just a vestigial organ, like it's just kind of an appendix, or like what does it do? So, it has a very high concentration of atrial natriuretic peptide and beta natriuretic peptide, and then it is more compliant when compared to left atrium, and then acts as a decompression chamber when left atrial pressure increases. So, it's kind of a cushion mechanism for your left atrium, and then LA remodeling and stasis of the left atrial pouch. As you can see, once the patients have chronic linear fibrillation, the left atrium kind of dilates, and then your left atrial appendage also kind of becomes kind of a cushion, and then you gets more dilated, and then you see a decreased left atrial emptying velocity, and then definitely no contribution towards cardiac output. So, history of left atrial appendage occlusion, dates back to 1949. I think it was by Dr. Madden up in New York, where he did accession of left atrial appendage on a patients who were undergoing bypass surgery. He did on 2 patients as kind of an prophylaxis to exclude that among patients who had atrial fibrillation. So that's where it all started. Take that off. Probably there is some stroke prophylaxis prevention from that. And this is kind of a meta-analysis which we usually when we mention that non-valvular atrial fibrillation, you always look for left atrial appendage, and then rheumatic valvular atrial fibrillation. Basically, there is high likelihood for left atrial cavity. As you can see, all those patients who have non-rheumatic atrial fibrillation, basically your non-valvular atrial fibrillation, they have more than 90% of them have thrombus burden in the left atrial appendage, as opposed to your valvular atrial fibrillation. They have only 57% of thrombus burden in the left atrial appendage. So that's why it's kind of the mechanism of treatment in terms of anticoagulation, everything kind of takes a different approach. And this is the meta-analysis where usually people tend to refer to. And then these are some of the studies based upon the surgical left atrial appendage. I'm not going to bore you with everything, but I'm just going to highlight on the most recent article, the Laos 3, which came out, a randomized controlled trial in 2021. Okay, let's just quickly briefly touch base on it. So it was a multicentric, randomized, double-blinded international trial. They included all patients with SHARVAS for more than 2. And it was an intention to treat analysis for patients undergoing cardiac surgery. Okay. The primary outcome was to assess if they have ischemic stroke or any kind of systemic embolization. So patients undergoing cardiac surgery occlude the appendage and see if there is any benefit out of it. So what they did is they did 3 approaches. Either they did a stapler to occlude the left atrial appendage, or amputation with suturing, or epicardial device, something which you might be familiar with, something like AtriClip, something like that. So as you can see, majority of them were attempted, and then close to 90% success rate in getting a good occlusion of the left atrial appendage. And then they were equal distribution of cut and sew was probably the majority of them, 55%, then staplers, closed device. So what were the outcomes? So most of these patients had to follow up for every 6 months to assess for the stroke based upon the questionnaire. And then they followed up for 3.8 years. Oral anticoagulation used during follow-up was they put in anticoagulation for both groups, and they was pretty compliant, close to 75 to 78% by the end of 3 years. So I would say it's a pretty reasonable compliance in terms of anticoagulation in both groups. So in the occlusion group, there was a significantly lower primary endpoint, which includes stroke and systemic embolization, when compared to the patients who did not have any occlusion performed. And then the primary endpoint, which include the stroke and systemic embolization, the statistically significant. Majority of the advantage was from stroke prevention. As you can see, systemic embolization or ischemic stroke was not statistically significant. And then majority of the difference came after your first 30 days. So somebody who got the surgery done, ischemic stroke or systemic embolization within first 30 days was no different between the LAO group or who did not have this procedure. And as I said, beyond 30 days, it was significantly different. So you would expect them to have some benefit after the first 30-day period. So now let's switch gears and then look at our percutaneous left atrial appendage. As most of you guys are aware of, there are a lot of these in the market. And then I think for this talk, we'll most likely try to limit ourselves to Watchman Flex. Plato was the pioneer, that's the first thing, then went off the market. I know a couple of people like to do Lariat and Amulet as well. So we'll kind of touch base on that and see what we can learn about it. Okay, so this is your Watchman, and then this is Watchman Flex. So basically, your nitronol framework with a mesh with the Watchman Flex did not have the end tied up together. So this was significantly limiting in terms of reposition and recapturing. So came up with a significant genius idea of trying to put it together. And also they gave more hooks, as you can see here, these anchoring devices. They gave 12 anchoring devices to get more stability in terms of when you deploy the device and then hooks into your left atrial appendage. So again, not to bore you, this is kind of a very busy slide. There are a couple of, and I just put it out there if you would want to take a look at it at your leisure. What were all the different kind of studies, and then what were the outcomes? So for us, we'll mostly limit to Watchman, as I said, Watchman Flex. 18 struts, nitronol framework, and on the mesh membrane. And has 12 anchoring devices. Usually you will have a 15-inch access, and then there are different sizing based upon which we'll talk, and you can pick and choose which will suit your patient the best. And then obviously Lariat, your epicardial device, which I think I know most of the hospitals are more Lariat when compared to Watchman Flex. Okay, so the procedure starts, as I said, put in French groin access, take a transeptal puncture. You need to limit it to more being into inferior and kind of a posterior region. We will talk why it is very important. And then once you're done, you go across into your left atrium, put a pigtail catheter, switch out with your Watchman implantation sheath. And then first you will try to put the pigtail catheter in the left atrial appendage. Try to, this is one way you can do under fluoroscopy, but we'll talk more in terms of how we can do it on echocardiography. Measure it and then take a fluoroscopic image to rule out if there is any small lobulation, or what am I looking at? Is it the anatomical, or is there is a different measurement where I need to look at? So kind of contrast will give you a good estimate. Put in, and again, this is your Watchman initial device, but whatever we are doing is more of a Watchman Flex. So as you can see, the struts are kind of open. Deploy a device, get good anchorage, and then you would want to take another fluoroscopic image to basically see if there is any contrast percolating back into the left atrial appendage. So that will kind of help you gauge whether there is any paradevice leak or not. And then unscrew it, and then you're out. And then you kind of endothelialize it, and then the appendage is occluded. This is kind of an idealistic approach where you would want that. So as I said, why it gets very important is this is your interatrial septum. You're looking at it from your right atrium. So it is very important you try to stick. So here, if you come more anterior, you're risking going through your aorta, and then if you're more superior, you're going through the more muscular part, and then you try to keep it more inferior and posterior. Reason being is if you keep it more inferior and posterior, you have a straight shot towards your left atrial appendage. As opposed to if you take a more kind of an anterior puncture, you're risking going through and through across the mitral valve more in kind of anterior direction. So then it gets really tricky that you have to angulate your implantation sheath to make it more coaxial with the left atrial appendage to get good positioning and good feel, because it's very important. Like, once you position it, you have to pull it and make sure, like, it's occluding appropriately, or else if you're placing it at an angle, then the whole device gets loses the purpose of the procedure. And let's see, let me think. Okay, all right. So you're trying to take a TE. This is a mid-superficial short actions view, and this is your bicable view 120. Trying to guide the intervention, let's say the EP or intervention cardiologist, in terms of, like, where you take the best approach. So try to keep it more posterior, kind of away from your aortic valve, and then trying to keep it more inferior in your bicable view. So this is a superior vena cava, inferior vena cava. Try to keep it more and more close to your inferior vena cava, like try to keep it down there. So this would be kind of an ideal position where you would want your transeptal puncture to go through. And then you would want to assess your cardiologist in terms of, like, because they're kind of tuned to looking at, like, in fluoroscopic images once they're deploying the device. This is your kind of ariocaudal view, and then what you can do is take the image in, like, 130 meters of axial, try to open up the left atrial appendage, kind of turn it around, like, flip it so that the interventionist is aware, okay, what am I looking at, like, how many lobes they are once they are looking at the fluoroscopic image. So kind of guide them. And this is a, like, really good paper by Dr. Sarich, which talks extensively about how views can help the intervention cardiologist in terms of which fluoroscopic view correlates with your TE view. So I would advise, if you guys have time, like, it's a very good resource. And again, ariocrani view, you take your 50 to 60, 16 bicable view, try to open up the appendage, and then, like, freeze the frame, turn it around. It gives your interventionist a view of, like, how my left atrial appendage is looking in terms of your ariocaudal view. Now comes the most important part, is what size of device I pick up. Okay, so the standard recommendation is you perform on-axis measurement of left atrial appendage, and you look at at least these angles, like 0, 45, 90, and 125. So you kind of open up the appendage, try to measure at the orifice, and then, like, take a perpendicular from the midway, and that kind of gives you, okay, where I am. And you do the measurement in all 4 angles. And whichever has the highest diameter is the device size which you're going to pick and choose. So here, as you can see, 0, 45, 90, and 135. The biggest diameter was noted to be at 0 degrees, which was 26 millimeters. So I would prefer to go on this diameter rather than going on a smaller diameter. Again, as I said, you're risking. If I'm going to pick and choose a smaller diameter device, I'm risking, like, a para device leak. Then I'm losing the whole purpose of doing this procedure in the first place. And this kind of becomes, like, very important. Where am I measuring? This is your anatomical orifice, which is not usually always the same as where you would be landing your Watchman device, which could be totally off. Like, this couple of millimeters will totally change what kind of device I'm going to pick and choose. If I'm going to use anatomical orifice, and if I'm not able to get good seal here, then the device, if I'm oversizing it, it's not going to fit in. On the contrary, if I'm going to undersize this, there's going to be huge para-device link. So it gets very crucial in terms of you assisting your intervention colleagues in terms of getting the right diameter for the orifice. So as Dr. Sarich always mentions, like, before you let your colleague know, that it's good, you always do this past checkpoint. So you check for the position. As I said, like, if you take your inferior and posterior approach, you get like, straight shot perpendicular at the left atrial appendage and gives you a good positioning, like, or else if you go like more anterior, gives you like at a tilt, and then the anchorage is not appropriate. So it's very important, like, transeptal puncture to get a good positioning, and then kind of do a tuck test, make sure it's very stable. Otherwise, you're risking device embolization. And then you would want the compression at least 15 to 30%. Like, the device, like the left atrial appendage is like in compressing the device, preventing it from opening, which then like, it is like fixed and it's in good position and it will not embolize. So that's kind of a gauge, like, if it is compressed by at least like 50 to 30%. And then obviously you will do a color Doppler on it. And then again, all angles, open up the left atrial appendage on axis, like, from 0 to 35 with color Doppler. Make sure there is no leak. Because even if there is a leak, it's very important that you document immediately post procedure. Yes, there was so and so millimeter leak. So then, because you're going to do 6 months, 45 days, or 45 days, 6 months follow up TEE, it will help you determine, okay, this leak, was this developing new or was it already there to begin? So that kind of gets like really very important. So again, like, successful implantation, like, no tilting here, perfectly horizontal. And then you're looking at any color flow around it. Absolutely no flow. This is your Watchman. No flow around it. Maybe a tiniest whiff. You would usually want it to be less than 5 millimeter. 5 millimeter leak is kind of your cutoff, and we'll talk why. So if it is, it tends to endothelialize, and then you can, like, say, like, it has a good success. So let's talk a little bit of studies which came up to your Watchman. So starting off with Protect AF trial, it was around 700 patients who were warfarin eligible with non-valvular atrial fibrillation, with randomized in a 2-to-1 fashion. Again, looking at your CHA2DS score, and then procedure failure rate was around 10%. This was like, interventional EP or a cardiologist was like, just getting their hands on it. So this procedure failure rate got significantly better as they got better at, like, exposure of it. Primary efficacy endpoint was stroke, systemic embolization, cardiovascular death, and all-cause presumed cardiovascular death. And then the safety endpoint were pericardial effusion requiring intervention or prolonged hospitalization, stroke or device embolization, and major bleeding, which included intracranial or requiring transfusions. And then procedure-related complication occurred around, like, 8.7%, of which predominantly was pericardial effusion. So this is kind of for your primary efficacy endpoint and primary safety endpoint. As you can see, it met the primary efficacy endpoint, but failed on the safety endpoint. On efficacy endpoint, the device started showing significant benefit, starting out around like 12 months, like around, I would say, like, 1 year. So that's when, like, it started showing real benefit. And then safety endpoints, initially the device had significant higher bleed, as you can see here in the device group when compared to the warfarin group. So failing on the safety endpoint. And again, trying to look again at the individual ischemic stroke, not making good progress over there, and then cardiovascular mortality and all-cause mortality were better in the device group. And then again, another like, kind of summarize as to total events, what constituted in each group, device group, and then warfarin group. So since it failed on the safety endpoint, FDA, before approving it, mandated for another randomized study just to look at the safety features. So they had to design a PREVAIL study in which they looked at all the patients from implant to 45 days, and then they randomized it based upon their left atrial appendage seal at 45 days TEE. Okay, if there was a good seal, so no anticoagulation was recommended, only 325 aspirin and Plavix. But if there was more leak, like which is more than 5 millimeter, they wanted patients to be on warfarin until in 6 months again when they repeated the TEE. If they found good seal, then they discontinued warfarin. Okay, And similarly for left atrial appendage, good seal group. Then looking at the Prevail group, again, it met its primary endpoint, and then it showed significant good implant success rate, and they continued to access this group in terms of product, continued to access CAP group, and then they looked at the p-value, which is again significantly different and better in Prevail group. And all 7-day procedure complications were also lower in the Prevail group. So again, this was primary event to look at the safety endpoint, and which it proved it. So again, going back, looking at the both groups on the chronic warfarin and then Watchman group, there was good outcomes in terms of safety endpoints as well. So Lao was found to be non-inferior to warfarin for ischemic stroke prevention or systemic embolization more than 7 days post procedure. Non-inferiority was not achieved for overall efficacy, which is stroke or death. Event rates were lower and numerically similar in both arms. So the Prevail trial provides additional evidence that left atrial appendage closure is safe and effective alternative to Coumadin in patients with non-valvular atrial fibrillation. So looking at a Watchman post-procedure complications, 7-day procedure or device-related complications, they continue to follow these patients in the CAP or continued access to Protect and CAP2, which is continued access to Prevail. And then as I said, as the operator became more familiar with the procedure, the technique, the operator-related complications decreased. And as you can see in the center where they have been performing more and more procedures, it decreased from 9.9% in Protect AF to half, 4.1%. Again, they try to look at the same population and the same center. They will continue to look at these patients, and then the operators, as they got better, the complication rates got better. So again, looking at all the trials, and then as the technical success got better, serious complications got lower, and so also major side effects. And I also wanted to touch base on a couple of other studies, which looking at Watchman Flex, and which is guided by intracardiac echocardiogram to in kind of implantation. So 91 patients underwent a pre-procedure CT, initial TEE in 8, but ICE was used in 83% patients. So as you can see, technical success rate was 99%, 5.5% procedure-related complications, 3.3% had peridevice leak on TEE upon follow-up, so pretty good, and no device-related thrombosis. And again, these patients were discharged on aspirin and Plavix, and then daily for 1 to 3 months, as opposed to conventional where they had to do Coumadin in the initial phase. So procedural short-term results with the new Watchman Flex left atrial appendage. So as I mentioned previously, since they put this the struts together, it became very efficient for them to kind of say, okay, I did not get a good capture. It's not well positioned. It's tilted. This gave them the opportunity to recapture and reposition it. So giving them 100% technical success rate, complete sealing in the large left atrial, trying to go more deep, try to get a good occlusion, lower rate of thromboembolic events, and then low procedure-related complications, 1.8%, and low device low incidence of peri-device leak, and absence of device dislodgement. And as I mentioned, there were more number of anchorage devices that gave more stability to the device as well. Just kind of an update from NCD Law Registry, as it started in 2016, they kind of kept a track of all the procedures until 2018, and saw what happened to these patients as more and more procedures were being performed in the hospital, and the physicians were getting better at it. They wanted to kind of keep a track of these complications with that. So as you can see, a lot more centers and a lot more procedures are being performed. Again, this is until December 2018, and then more hospitals are starting up with this process. And then success rate is success rate is like pretty 95 and above. And then in hospital event rates were pretty low. And kind of a timeline on all the Watchmen, like as I said, like started with Plato in 2001, and then went off market. Then started with Watchmen, and then Protect AF, ASAP, Protect AF long-term results, FDA approval are like roughly around in 2015, and then more studies around the Watchmen. And then also looking on the surgical standpoint, the Laos studies, and then FDA giving like safety communication about the surgical left atrial appendage as well. Post-law anticoagulation, this comes like most frequently when you're talking to the patient in terms of what kind of anticoagulation I'm going to give you after the procedure. Like, and sometimes you will always also encounter like patients say, okay, doc, I have read about this Watchman. I want to get this procedure in lieu of taking anticoagulation. I don't want to do anticoagulation. So as I said, like this is not a class 1 indication. It's a class 2B among patients who are not able to tolerate long-term anticoagulation. So still, long-term anticoagulation is your class 1 medication. So now, once they got the device done, what do I do? So if you look as per the Protect AF trial, they were doing 45 days of warfarin plus aspirin, and then they did a TE at the 45-day mark. And if there was minimal, as I said, like less than 5 millimeter peri-device leak, they were taking them off of anticoagulation and continue aspirin. And then 6 months of Plavix and aspirin, and then aspirin only. So if device leak was present, you will continue warfarin for until 6 months, and then repeat a TEE, and then look at if there was good endothelialization or if there was any peri-device leak. So that's one approach one would take. And now also looking at the ASAP study, like in which the patients were not anticoagulated, they started off with excuse me, started off with aspirin among like again, this was done to look at non-randomized multicentric patients. In 150 patients, they looked at 6 months of clopidogrel, all lifelong aspirin plus lifelong aspirin, and then they found they were like all cause strokes were 2.3%. So the whole premises in this they looked at is what if they did not take anything as opposed to taking aspirin and Plavix. I mean, like it's give and take. I know a couple of people go by have been using this trial as a backbone in terms of doing only aspirin and Plavix. Again, it's operator preference. However, recently FDA in September gave a great signal that you can do only that as an alternative antithrombotic in patients who get this Watchman device. So again, your preference. So one will usually also ask, like in terms of bacterial prophylaxis. Okay, what do I do? So it's kind of a foreign material. So until it endothelializes, usually around kind of a 6-month mark. So recommendation is to do prophylaxis just as you would do for infective endocarditis. And after 6 months, you anticipate that the endothelialization has been completed, and then the bacterial prophylaxis are not anymore necessary. And then this also comes across very often, like okay, somebody has Watchman. What do I do in terms of cardioversion? So if you look at the package insert by the manufacturer, they recommend against cardioversion for the first 30 days after the procedure. But again, however, if there is a patient who is hemodynamically unstable VC or like VF, if you cardiovert them, ideally you would want to make sure you check the position of the device after the cardioversion. But if you have to stabilize the patient, shock him, and then always you can look at the device if that's embolized or not. This is kind of a like explanted amulet and Watchman. Here I just wanted to kind of emphasize like how it like kind of endothelializes, and this is kind of a hematology HE stain. Looking at the amulet, this is your fibrosis, your device, and then the capture part, and then similar for the Watchman. This is your fibrosis part, or the appendage where it looks fibrosed, and then this is the attachment part. And again, looking at good endothelialization, this is your framework, and then good endothelialization. And this is on your electron microscopy. So compared to Amulet, Watchman was noted to have little delay in terms of endothelialization. Again, this is like a very small number of patients who, I think animal models who got explanted after and looked into with electron microscopy. I'm not sure if there is any evidence in terms of human patients having delay in terms of endothelialization. But again, I just wanted to kind of show you, see, in terms of endothelialization between the amulet and then watchman. There are some new kind of occlusion devices coming on the market. Like, most recently, there was this foam-based occlusion device, which sounded like, very promising, because, as you know, there are different varieties of morphology of retracted appendage. Anchorage may not be very good in terms of, like, if you have a very short appendage or like, cactus kind of morphology. So the foam based sounds very promising. So just as you know, as it suggests, like, it sits in the cavity, endothelializes, and they were and this is kind of a very small, like 15 patients only, with a shadow square of 4 and above. I mean, sorry, average shadow score of 4. Technical success rate was 100%. Absolutely no patient had more than 5 millimeter peri-device leak, and only one patient had device-related thrombus and no systemic thromboembolism or device embolization. So sounds very promising. Again, like, only 15 patients. I don't know if you could draw a whole lot of conclusion just from this small population, but something very interesting. Probably a large-scale study might be beneficial. And then I just wanted to finish off with some of our studies, which we looked into a national database to see what's the trend been in terms of after the FDA approval. So as you can see, the numbers have not double, triple, like, it's significantly exponentially grown in terms of starting off with like maybe few thousands to like almost reaching around 11,000 to 12,000 by the end of 2017 with a significantly different and then the mortality rate has significantly gone down. Like, this is as again goes off saying, as a procedural experience gets better, the mortality is going down, procedure related mortality, and then like, pretty good success rate. And this is one of our paper in which we looked into the patients who had watchmen, and then we propensity matched with patients who did not have watchmen from, again, nationally. That is, what happens if these patients don't get watchman device and take a similar population. We matched based upon their 31 comorbidities, age, gender. And then kind of looking at all-cause in-hospital mortality, complications, 30-day readmission. And as you can see here on the right side, like, all-cause mortality was lower, and then all-cause 30-day readmission was lower among the appendage occlusion group. Again, device-related complications such as pericardial effusion was higher among the device group, and then pericardial synthesis blood transfusion was higher. And then looking at some of the other complications, again, this is when they say readmitted, and what happened to them during readmission. Higher reasons during readmission had like more pericardial effusion, pericardial synthesis. Again, this is more in terms of patients who had the watchman device. Majority of them require transfusion. And but if they get readmitted, in-hospital mortality was still lower among the patients who had the watchman device implanted. And majority of the patients who did not get the watchman device implanted, the most common reason for their readmission was paroxysmal atrial fibrillation, as opposed to patients who got device done. The most common reason for their readmission was GI bleed. Something interesting from this data which we learned. And then we recently also published trying to look at see if from procedural standpoint, like, I know a lot of people have been doing it in terms of like, doing AFib ablation, and then go in before you come out, you already have a transeptal puncture, put in the watchman device, come out. So can we do it? Is it possible? So this coming again from the National Readmission Database, looking from patients from 2016 to 2019. Again, propensity matching, trying to see, like, number one, is it feasible? How it is being performed? Number two is to see, like, what happens. Does the complication rate go high? Does the readmission rate go high? So what we found is readmission rate is not statistically significant in a group who get the combined watchman and AFib procedure done during the same day. versus who get only Watchman or who get only AFib ablation. Number one. Number two, yes, they were like approximately 375 patients who got combined procedure done on the same day in the United States. So something very intuitive, like, I think one of my mentors from London, he was mentioning they have been adopting more and more this approach. And then talking to a couple of my mentors, they have been doing this. But again, short study to look at, like, it can be done and then low complication risk. And again, here just kind of showing the whole complications, which include pericardial effusion, pericardial synthesis, requiring blood transfusion, stroke, and hospital mortality. None of them were statistically different between three groups. The only thing which came out significantly different was length of hospitalization. Again, I would not make a whole lot of difference here between 1 and 3 days. Majority of them were discharged home and all the groups. And then even during readmission, our MACE was not significantly different between each of the group. Again, the numbers were very small. Again, this is national data which we're talking about. So feasible, can be done, no difference in complication. So here we end, and these are some of my references. And then I really thank everybody for joining today. And this is what I had for today. I'll be happy to take any questions.
If you have questions, please write them in the chat box. We'll give it a couple minutes here. And in the meantime, again, thank you, Dr. Pospula, for your time.
Sure.
And we will be putting up this recording on the ACC Minnesota website for future review. So it's always a lot of information, I know.
Yeah, in a short time, a lot of people would want to take their time to review it again, or like pause it, and then absolutely.
I don't see any questions here. So I think that we will let you go. Perhaps people can contact you if they have questions in the future.
Absolutely. I'll my email address here if you would talk to me about any question in terms of presentation, or if you have any general questions, or like want to collaborate on a research, I'm very happy to do that. So please.
Wonderful. Great. Well, thank you again, and everyone have a wonderful evening.
You too. Thank you, Claire, for organizing this. Thank you, everyone. Take care. Bye-bye.
Okay.